Okay, sir. I've clicked on slideshow.
Yeah, it's there now. Can go ahead.
I'll be presenting November 2023 National Postgraduate Medical College General Medicine Question 3. A 62-year-old man known hypertensive presented to the A&E with history of breathlessness and bilateral leg swelling. His pulse rate is 130 beats per minute, blood pressure 110/60, heart sounds S1, S2, S3, has bibasal fine crepitations. The registrar on call reviewed and made assessment of acute heart failure. He gave him 100 milligrams of furosemide with no improvement. After 30 minutes, he gave another 80 milligrams of furosemide and his condition deteriorated. His relatives were angry and said that they are taking him to another hospital. Question A, what did the registrar do wrong? B, what should he have done immediately? C, what urgent investigation should he have requested? D, what will you recommend to the hospital management for the registrar? A, what did the registrar do wrong? Number one, we don't have a documentation of a complete cardiovascular examination for this patient. No record of elevated JVP, which will have helped in his assessment of acute heart failure. It's not complete assessment. There was no documentation of the etiology of precipitant of the heart failure. Then the repeating of the dose of the furosemide before the duration of action has expired, which is 4 to 6 hours. He repeated it 30 minutes after, it's wrong. Then he did not tell the relatives about the patient's condition and prognosis, which might have led to their action. B, what should he have done? He should have communicated the patient's diagnosis, cause of disease, protocol of management and prognosis with the relative. He should have investigated patients properly, like a chest X-ray was not done, which will have shown that, okay, is that failure? He should have examined patients. Okay, he should have informed the senior colleague about the patient's condition or worsening state before he gave the 80 milligram of furosemide. And there was no documentation that he examined the patient or he tried resuscitating based on the finding of his examination. No mention was made of an ionotrope to help this patient that he claimed to be in heart failure. The investigation that he should have done, I talked about chest X-ray, which might take a long time before the film is ready. He could have done an ECG, but the chest X-ray will show us that this is actually heart failure. ECG will, if ECG is abnormal, these are the findings we'll find. If it is normal, it's not heart failure. It's unlikely to be heart failure. Let me use that term. If it is heart failure, the following findings will be available on the ECG. Atrial fibrillation, Q waves may be seen, left ventricular hypertrophy, wide QRS complexes. All this will support that there is heart failure. Then natriuretic peptide, the N-terminal pro-BNP, will also help us as an investigation that I can also quickly do. If the BNP is less than 100 picograms per mil, makes heart failure unlikely. If it is greater than 500 picograms per mil, its heart failure is likely. Then for the N-terminal pro-BNP, if it's less than 300 picograms per mil, heart failure is unlikely. If it's higher than 900, then heart failure is likely. What will I recommend for the management concerning, well, this kind of incidents, a punitive measure will also help so that it will help other deterrents for future so that he himself or other people will not take similar actions. Number one, he can be given extra call. He can be told to have a presentation on acute heart failure and his complications and management to tell us. He can get be instructed to get clinical guidelines and protocols to read on medical emergencies. He will be told that he must always inform senior colleagues when he's he's having patients to care for. Then we can also recommend refresher course for him in emergency medicine. Clinical governance. I'll go over to clinical governance. Clinical governance is a system through which organizations are accountable for continuously improving the quality of their services and safeguarding high standard of care by creating an environment in which clinical excellence can flourish. The 7 pillars of clinical governance are evidence-based care and effectiveness, risk management, patient and public involvement, clinical audit, staffing and staff management, education and training, information and information technology. The next thing about clinical guidance that I want to talk about is what it stands for. It ensures that healthcare organizations use the best evidence and research, but for the first one about evidence-based care and effectiveness, ensures healthcare organizations use the best evidence and research for optimum outcomes for their patients. How? By following evidence-based practices when deciding on treatment options, sticking to standards and guidelines to help inform care, carrying out new research to inform new guidelines, papers and protocols and standards, implementing the new standards and guidelines into practice as they are being developed. On risk management, this is a method to understand, monitor, and minimize risk, both to patients and staff. It ensures that any past mistake or accidents are learned from, so the quality of patient care is improved. How is it done? Carrying out risk assessments, reporting any incidents or near misses, identifying any problem areas in treatment, and ensuring that the risk systems are in place and protocols are followed. The patient and public involvement means communicating with patients and the public to gain insight into the quality of care given and to address any issues that arises. How? By carrying out patient questionnaire, by implementing patient forums, and including representatives for patients on practice and hospital boards. The next one is clinical audit. This is carried out to evaluate the standard of existing care against the gold standard. It ensures any shortcomings are identified, enabling staff to develop methods to improve outcomes by carrying out an audit and researching a standard to compare to, collecting data from audits and comparing standard and analyzing it to identify shortcomings, implementing any methods of change, and re-auditing after a certain time has passed to assess the level of improvement. 5, staffing and staff management ensures that the right staffs are employed for the right jobs, professional development is encouraged, and a good working environment is put in place. This includes underperforming staffs being highlighted and helped to improve, encouraging staff to actively participate in the work environment, ensuring the employer has an open attitude to improve working conditions and appropriate staff management where necessary. Under education and training, this ensures that their knowledge and practice is both up to date and evolving as new developments in healthcare are identified. So the best possible care is given at all times. How? By creating pathways into further education for the staff through degrees and diplomas, encouraging staff to attend lectures, webinars, update courses, carrying out work appraisal with staff to assess their competency and identify areas of improvement. On information and information technology, this ensures that patient information is safe, correct, and up to date on all systems by implementing the correct storage and management of data and keeping patients' data confidential. The key components of CG include clinical governance, leadership behavior, policies, procedures, monitoring and improvement mechanisms, that all these are directed towards ensuring good clinical outcomes. The domains of clinical governance: 1, setting standards supported by evidence-based guidance; 2, delivering the standards through clinical governance and professional lifelong learning and self-regulation; then 3, monitoring standards by the Care Quality Commission and performance management. The responsibilities under clinical governance for the regulatory bodies or health agencies. Number 1, their roles include monitoring. Where relevant, they will enforce compliance with standard regulations, share information and intelligence in relation to patient safety, promote a culture of continuous improvement and learning, acting decisively to protect the public when risk to patients or patient well-being emerges. The role of the organization, healthcare organization or institution, is to put in place clinical governance systems which promote and protect the interests of patients and create an environment which supports healthcare in meeting their professional obligations. Concerning the healthcare workers, they should practice in accordance with the principles and values set out in good medical practice and participate in revalidation. Participate in systems and processes put in place by the organization to protect and improve patients' care. And the last one is strategic vision, participation, accountability, transparency, and the rule of law as the 5 key governance principles in the health setting. This is my reference. Thank you.
Okay, thank you, Dr. Olaitoun, for a wonderful presentation. Class is open for contributions, comments, questions. You can type in the chat box, or you can raise your hand electronically and make your contributions. Any comments, any contributions? Any comments from the chat box? Just 2 comments so far.
If guys need to comment, contributions, the discussions that we all learn from each other.
Okay.
Hello. Hello. Good morning.
Yeah. Good morning.
Good morning. Good morning, teachers and colleagues. Thank you, Dr. Olaitoun, for the presentation. I'm sorry I joined a bit late, so I noticed a few things that I was not really following. I want to ask for clarification. So the first thing I was wondering is actually, why did this patient really deteriorate on the clinical side of things? And then in terms of the generic competencies, I would like maybe a just quick recap of what clinical governance really is and how it ties in with this case. I think that's what I really want. Thank you.
Okay, sir. Thank you. Well, why the patient deteriorated? The blood pressure of the patient was 110/60, and the registrar had given 100 milligram furosemide, which will further lower the blood pressure. And he repeated this, the same furosemide 30 minutes after, another 80 milligram. So that could have tipped the patient into hypotension. and he did not add inotropes to even his treatment regimen. We're not told he gave anything apart from furosemide. So that could have been the problem, the reason why the patient deteriorated. Then concerning how clinical governance ties with this case, I defined clinical governance as the system that is put in place to make organizations accountable for continuously improving the quality of their services and making sure that there is high standard of care for these patients. This registrar, let me say, contributed to the deterioration of the patients because of the actions that he took and the ones that he was supposed to take that he did not take. So the hospital management is supposed to do something about that incident because he has not given the patient the best of care. He has not followed the evidence-based guidelines effectively, and maybe he did not have adequate knowledge, he was not trained, or he was not up to date with training. So that is why this issue of clinical governance, I think, came in.
Thank you.
Okay, good morning all.
Good morning.
Can I make a comment?
Yeah, you can go ahead.
Okay, thank you very much, Doctor, for the excellent presentation. Like we know, furosemide has little or no effect on blood pressure reduction. So 100 milligrams of furosemide is not too much, and I even sometimes can give up to 240 patients who are really congested. So I think giving furosemide is not out of place in this case, especially that the patient has S3 and biphasic reputation. So if you say he didn't do a detailed cardiovascular examination, that's correct. And then we don't routinely use inotropes in heart failure. You only use inotropes when the patient is in cardiogenic shock. Blood pressure of 110/60 is fair. And then he didn't document cold extremities. So I don't think there's need for use of inotropes in this case. So if the diagnosis really is heart failure, then I think the question is was not properly recorded. That's my own contribution. Or maybe because he didn't address the etiology, he would say that he did not identify the precipitant of the heart failure. And if you have not addressed the precipitant, then sometimes even giving your anti-failure regimen may not work effectively. Thank you.
Okay, sir. Thank you, sir.
Thank you for your contribution. Dr. Yusuf, you can go ahead.
Yeah, thank you very much, the classroom. So thank you for the presentation. My little is like a form of question. The first question asks that what is the management supposed to do to the registrar or something like that? If I could get the question properly. I think the first thing, I stand to be corrected, I think there should be a query needs to be issued to the registrar to give the registrar the opportunity to put in writing what he has done, and so that the management, maybe the head of department, can now look at. It's not just like a form of a query that he should answer a query, as in for him to defend what he has done. So it is based on what he has done that you can now be able to see whether he has done something wrong or he has not done anything wrong before we can now put in any punitive measures or punishment for him. So I think usually in official settings, if things like that go wrong, they need to issue a query first. I think that should be the starting point before we can say you want to either punish him or you want to do whatever you want to do. So I don't know whether that is right, but I just think there's a need to first issue a query first and let him put in writing what he has done. Thank you. So our seniors, teachers can comment on that. Thank you.
Okay, sir. Thank you, sir.
Thank you for your contribution, Dr. Ryan. Any other contribution before I go to the chat box? Any other contribution? Okay, let me read some of the messages from the chat box. Okay, Dr. Chika said one of the tests to do is a renal function test. Dr. Olalekan said, I think putting up protocol for management of acute emergencies at the emergency unit will also help to guide the registrar in proper management of acute emergencies. Dr. Jennifer said ionotropes are not given routinely. Yeah, I think Dr. Alpha had reiterated that. It is also important to find out if the registrar gave oxygen therapy. Dr. Emmanuel said, I also have issues with the hospital. Was there a protocol or management? Dr. Ekele said, thanks so much for the wonderful, I think furosemide can lower blood pressure. Dr. Emmanuel also said it should be pasted in the ER and also available online for quick clarification. Dr. Opute said patient-centered care, filling an incident form, carrying out a clinical audit to compare the practice of the hospital to standard care. So these are the messages in the chat box. Any other comment? Okay. Okay. Chief Shutu, sir. Good morning, sir. You can.
Yeah, good morning. Yes, I'm trying to understand this question. I'm a bit lost about the structure of this question. Were we given a case note or something?
Sir, sorry, sir. Sir, this is Dr. Fatima. Can I chip in? I was
Yes,
in the
please go
exams.
ahead. I'm trying to understand the structure of this question.
Okay, so actually, I think Dr. Abimbola Olaitan, you didn't even consider the heading of this question.
Yes,
You only answered the heading during other discussion after answering the question. So this is not a management question. It's not all about what is effective in heart failure, what did the protocol say and all that. It's all about clinical governance. So what they need is for you to apply your knowledge of clinical governance in answering this question. Because when we started, they were telling us to go back and look at the heading. So if you forget about the heading and focus on heart failure, they will not even accept it. They will not allow you progress. So the first thing, what did the registrar do wrong? It's all about involving his team. He managed this patient alone. So if you look at the components of clinical governance, it's all about teamwork, clinical audit, openness, communication. He didn't communicate with the relatives. He managed the patient alone. So you look at the clinical components and answer it that way. About the what should be done first, what they wanted is to put the patient at cardiac position 45 degrees head up. Because we said so many things, that is what they corrected us on. Then what should the management, can you go to the question, please? It's like, this is all about the information. This information is not as relevant as looking at the issue of clinical governance. So what should have been done immediately? So what should have been done immediately is to put the patient at cardiac degrees head up. That is what they wanted. Because if, as you are saying the wrong answer, they will just correct you and move on. Then what urgent investigation should have been requested? What they wanted is chest X-ray. You will say NT-probe, ECG. No, number one investigation they wanted for this question is chest X-ray. Then what will you recommend the hospital regarding management, to the hospital management for the registrar? It's not about query. You look at the components of the clinical governance, education and training, risk management, openness, teamwork and communication, clinical effectiveness, clinical audit. So this is where you talk in details of each component, looking at the scenario and applying it on the registrar. So this is my comment. Thank you.
Thank you, ma'am.
Thank you for wonderful contribution. Chief Shutu, sir.
Yeah, so I was thinking about the same thing as Dr. Fatima pointed out. Sometimes the way the question is structured, you won't understand unless you hear the heading. Obviously, the heading here was clinical governance, then yes, it now makes a lot of sense. And as Dr. Fatima had pointed out, that is how you should go about answering this question. What this registrar did wrong is that he managed the patient on his own. He didn't involve his superiors. He did not communicate with either his superior or even with the patient. And the registrar also forgot the fact that he doesn't own the patient, it's the consultant that owns the patient. And that he needs to, when one plan had been given to the patient, before instituting another dose of Lasix, they should have informed the consultant first to say, oh, these are the current problems of the patient, and da 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 da. Also, the patient came in, he didn't do any investigations to actually prove that his findings were in keeping with heart failure. And that's why I suspect they asked about what investigation can you do. And yes, we talked about the chest x-ray and all of that. That is what you can do on the fly. Of course, we know that echocardiography is the gold standard in making a diagnosis of heart failure, but you may not get that done on an emergency basis. So chest x-ray is an okay answer for that. But what I'm pointing out here is that the question was not about whether he gave the adequate drugs or he didn't, or whether his management plan was right or wrong. The major thing here was, did he follow the necessary articles that are written out in clinical governance? Yeah, and that is what they are actually testing. Okay, and part of clinical governance as well is education and training and all of that. So he may need to have further education and training on how to communicate properly. Also on the management of specific diseases, particularly heart failure case as well. Now, for the comment on whether the young man should have a query, yes, if his consultant deems it fit that he did not communicate adequately with him or the more senior people in the unit, then yes, he can get a query. But he won't get a query straight from the hospital. He'll get a query from consultant, and then whatever the consultant feels, if the consultant feels his response is adequate or not, is adequate, fine, it may end at the level of the unit, but if it's not adequate, it may be escalated to become a departmental issue, which will eventually can become a hospital issue. Okay, but whether he needs to get a query or not may not be in the wheelhouse of this question. It's not a case, it's not a management question per se, as in it's a hospital management question. So they just wanted to test whether you understand both the parts or the articles in clinical governance. Yeah, that's what I just wanted to put forward. Because the question, the structure of the question got me thrown off. So it's now that I understand what the question is about. Yeah, so National can do this to you. So it's important to know those all those generic competencies for you to be able to answer National questions successfully. And then always look at the heading. The headings always tell you what direction to go. Yeah, thank you.
Thank you
you,
very
sir.
much, sir. For wonderful
Thank you,
contribution.
sir.
Yes, sir.
Yeah, you can hear me, right?
Yeah, we can hear you, sir.
Yeah, Dr. Lighton, well, don't feel bad. Even me, I didn't understand what you were asking for. And that is practically only people that went to exam that will understand what they want. I actually feel as if it's not a fair question. Abba, if you want to ask about clinical governance, go straight and ask about clinical governance. Which one is what did the registrar do wrong? Someone will start thinking, was it a wrong diagnosis? Was it wrong treatment? It's not actually not a fair question. Chief Shitu, please tell your guy
but from the heading of the question, and the question is usually on the table, and you see the heading of the question.
It doesn't matter. The heading, yes, is clinical
The
governance.
heading is clinical
But you're asking the
governance.
person, what did the registrar do wrong?
Yeah, what did he do wrong in the context of clinical governance?
In fact, it's even, if you had said that, if you had added in
No,
the
but the
concept
heading
of
is
clinical
clinical
governance,
governance.
it would have been fairer. Please tell
No,
your chief that they should stop checking this kind of questions. Not fair.
The truth of the matter is the question is fair if they had put there that it was a clinical governance question.
Exactly. If the candidate,
But they usually write it. They always write it. They always write it. It's the opening heading of every question. You always write it on the question.
That's actually
if it
one of
was
the
active
benefits.
medicine, then that's different. Yeah.
Yeah,
But
that's actually one of the benefits of being in this class. so that you understand what is needed. You can hear by the time it's someone who went for the exam just talked, everybody now said, If I even me, I was like, now it makes sense. So, but it's okay. I immediately saw that initial, what did he do wrong? I started wondering, was it, for example, that he didn't even monitor? Because a patient like that should be on monitoring, multi-parameter monitoring, especially when they are talking about getting worse. You know, when patient is getting worse. But I think what you wanted to say is that when patient is getting worse, or when you try, you need to involve your team. Okay, so well, it's okay. It's much clearer now. Thank you.
Thank you, sir.
Thank you, sir, for the contribution. Any other questions or clarification? While the second person should prepare his or her slides for sharing. Dr. Lighton, you can answer.
Okay, sir. I don't know if you have spoken already.
Who? Hello? I didn't get that one.
Dr. Yusuf, I don't know if you have spoken already. Is that still up?
No, he has spoken. Yes,
Ibrahim.
he
Okay.
has spoken already. Yes, yes, ma'am.
Okay. Then, well done to the presenter. I think the essence of this whole presentation is to learn from those that went for the exam, our facilitators, and even the participants themselves. So that in case this question is repeated, you already have, even if it's not repeated, if they bring a similar question, you know how to go around it. So well done to the speaker.
Chief Christopher, at least now they know that the heading is very, very, very key. Always look at the heading first before you even read the question.
Exactly, sir.
The next presenter, please. Can you share your slides? Dr. Faboyinde Olabisi, Dr. Musa Abdurrahman, Dr. Sani Abubakar. You guys are the only one left from the
Dr. Sani Abubakar is in class.
Good morning, ma.
Colleagues, I'm going to present on question 11 of the National Postgraduate Medical College, November 2023 recall. So the question goes like this. Sorry. Why is it not moving? Okay. It's question 11. You are a physician in a state with documented increase in the incidence, morbidity, and mortality of colorectal cancer. Patients are complaining of abdominal discomfort following colonoscopy. There is a new test called the fecal immunohistochemistry test, which can help to diagnose colorectal cancer. You are asked to carry out a study to determine the diagnostic utility of FIT in diagnosing colorectal cancer. So the questions that followed: what will be the title of the research, the main aims and specific objectives of the research, 4 research questions, 2 key focal areas of literature review, components of the methodology, that is, what are the components of methodology, the study design that will be preferred, and what are the statistical tools you will use in data analysis, and how will you present your findings to the CMD. So I will start by giving the title. So my title of the research is going to be determining the diagnostic accuracy and clinical utility of fecal immunohistochemistry test in colorectal cancer. So that's a very simple, just simplify it and give a very simple topic. So the main aim of the research is going to be to investigate the diagnostic accuracy and clinical utility of fecal immunohistochemistry test for colorectal cancer. So the specific objectives will include to evaluate the sensitivity and specificity of fecal immunohistochemistry test in determining colorectal cancer, comparing with colonoscopy. Actually, in determining the diagnostic utility, you need sensitivity, specificity, the negative and positive predictive values, superiorities, and also you can assess other clinical utilities like cost effectiveness and its implication, ease of use. So based on that, I have coined the specific objectives to evaluate the sensitivity and specificity. Now to determine the superiority of fecal immunohistochemistry test against colonoscopy, and to determine the cost effectiveness of the fecal immunohistochemistry test in detecting precancerous lesions and also the cancer itself and prevention. How can it be used for prevention? So the 4 research questions that were asked, I would like to answer them the following way. What is the sensitivity and specificity of FIT in detecting colorectal cancer, and how does it compare to the established screening method, that is colonoscopy? What are the rates of false positive and false negative results associated with FIT? And how does FIT test vary across the different stages of colorectal cancer? And can the test reliably identify early stage cancers compared to advanced stages? And to what extent does FIT testing contribute to the cost effectiveness of colorectal cancer screening program? So the areas of literature review that I would like to consider will include reviewing the literature on colorectal cancers and screening methods available with researches on their sensitivity, specificity, and their accuracy, and also reviewing existing literature on FIT as a screening test. So then the components of methodology. The components of methodology usually include the study location, where we are going to identify and give a brief description of the target location where the study is going to be carried out. That is, then you go to the study population. We are going to give a brief description of the target population from where they will be recruited. Then you also like to get like the participants from a population that are eligible for colorectal cancer screening, including individuals that are at high risk and also having the demographic characteristics, for example, age and other factors. Then then you can obtain informed consent from the participants to clearly explain the study objectives, the procedures involved, the potential risk of the procedures, and the benefits of each of the tests. Then we can get the inclusion and exclusion criteria, which usually vary based on the design, the study design, which I would like to explain subsequently. Then the study period, based on the design you are going to do. If it's a cross-sectional, it's going to be a snapshot and for a short period of time. Then the sample size determination usually also depends on the design that you want to actually use. Then the study protocol, we are going to give details of how we are going to carry out the procedures, like you are going to collect baseline information, including demographic data, medical history, family history of colorectal cancers, and other risk factors for colorectal cancers from the patient. Then you administer the tests, that is the FIT and also colonoscopy, and you try to collect as much samples as you can get from each participant so that you can have reliability and that you have collected enough samples. Then you schedule colonoscopy as well for the participant, because depending on the nature of the test, the study design, some would like to do them separately and some would like to combine the 2 tests. Then as a continuation, you like to the sampling technique, where you can use the simple random sampling methods, or you can use consecutive methods depending on your design. The study materials, you list them out, the equipment and the reagents necessary, and then the data management and statistical analysis, which I'll also say something about it later on. Then ethical considerations. Now about the study designs. In studying tests determine their diagnostic utility or diagnostic accuracy, there are several designs that can be used, but the most superior one that is recently been piloted is the diagnostic randomized study, which is also an RCT, an experimental study where you can have two groups, and then you are trying to compare two or more interventions, and the two groups are usually matched to one another, one with a new intervention and the other one will receive a placebo. Then you compare the data from the two groups. It has the advantage of giving us assessing clinical outcomes, unlike the other forms of the test. Sometimes if time is against someone or you want to have a rapid result, you can go for a diagnostic accuracy cross-sectional study, where each candidate will receive a colonoscopy and FIT. The participants may have or may not have the disease, and then results of both tests are being compared and accuracy statistics calculated subsequently. The advantage of this is that it's cost-effective, easy to perform, and you can have your prevalence. And also, it is it is advantageous if the disease is rare. But from the question, they said that the incidence is rising, and so the prevalence is also rising. So the disease is no more rare. So a cross-sectional study can be done, but the setbacks is that you cannot calculate some other outcomes using this design. Then the statistical tools I would like to use, definitely we will use the descriptive statistics so that we can summarize the data in terms of frequency, tail distributions, determine the standard deviations, mean, and others. I also like to analyze the diagnostic accuracy, which will involve calculating the sensitivity, specificity, positive predictive value, and negative predictive values. So you also like to do the survival analysis. Maybe you can use the Kaplan-Meier curves or the Cox proportional hazard to analyze from time to event outcome, such as the time onto development of colorectal cancer, and assess the impact of FIT on survival. It allows you to assess hazard ratios, and this survival analysis can only be done in an RCT most of the time. Then you can also utilize statistical methods such as logistic regression to find associations between the test and the outcomes after adjusting for confounders using logistic regressions. Then you can also adjust for baseline differences between groups when you have continuous variables by using ANCOVA. And you can also perform a subgroup analysis where you can stratify the patient based on age, gender, risk factors to assess whether diagnostic performance of FIT varies across the different population characteristics. And you can also compare means, where you can use the chi-square to determine the differences between groups if the variables are categorical, and t-test if they are continuous and they are normally distributed. So to the last aspect of the presentation, how are we going to present our information to the CMD? I'll first of all like to give a brief introduction where the research topic and its significance in colorectal cancer screening. Then I'll also state the objectives of the study. Then I'll also go to give a brief background of the study, provide a brief and concise information about colorectal cancer, emphasizing for the need for accurate and efficient screening methods. Then I also like to highlight existing screening methods and their limitations, summarizing demographic characteristics of the study participants, and highlight any notable factor relevant to the study, such as age distribution and risk factors. And also then I will present the result of the study, where I'm going to present the diagnostic accuracy measures for the FIT, display the key findings, including sensitivity, specificity, positive predictive value, negative predictive value, and overall accuracy. Would you like to use visual aids to ease presentation of these numbers, and also graphs to give a better outlook? Then present any findings related to survival, that is demonstrating the impact of FIT results on the time to event outcomes. And also there's a point we call the clinical utility, where you are going to talk about the economic implications, the cost effectiveness, and other merits of the disease, and how it can be utilized. Then discuss how FIT tests compare with existing screening methods to show the superiority of FIT, or they are comparable head-to-head, or there's an inferiority between the two. And then I will make some recommendations to the hospital based on the findings, provide clear recommendations for integrating FIT if it turns out to be good based from the accuracy tests, and also discuss potential benefits, that is being easy to perform, no pain, and it also has a comparable outcome or a comparable diagnostic quality compared to colonoscopy. Then give a conclusion summarizing our key findings and their implications for clinical practice. Okay. I hope I can be heard.
Yes, you can be heard.
Okay. So this is the last part of the presentation. So I would like to talk about some few of these diagnostic accuracy tests that I've mentioned. So diagnostic accuracy of a test is really the ability of a test to find subjects affected by a given disease as positive and subject not affected by the disease as negative. So the mostly used tools are the sensitivity, specificity, positive predictive value, and negative predictive value with likelihood are usually derived from sensitivity and specificity, as well as the ROC curve and the diagnostic odds ratio. So diagnostic, sometimes in some literatures, diagnostic performance will include the positive predictive value and the negative predictive value with the likelihood ratio. Diagnostic accuracy is being limited to sensitivity and specificity only. So by way of definition, sensitivity is the ability of a test to detect the disease when it is truly present. And usually the formula is that you get the true positive, you make a 2x2 table, the true positives divided by the true positive plus the false negatives. That is false negative in this case, those that actually have the disease, but the test picked them as they don't have the disease. So they truly have the disease. So you add them up and you get the ratio. The sensitivity is usually the true positive ratio, while specificity is the probability of the test to exclude the disease in a patient who truly do not have the disease. And the formula is usually true negatives divided by the true negative plus the false positive. Then the positive predictive value, the probability of having the disease of interest in subject with positive test, while the negative predictive value, the probability of not having the disease in a subject with a negative test. So as I mentioned earlier, there's something called the clinical utility, and just try it will give you like the knowledge and the perspective of the supporting evidence and the level of that evidence. So you ask some few questions: what evidence is currently available? What is the minimum threshold of evidence to gain general acceptance? That is, how can it be used clinically? How should the evidence be generated in terms of the study design, if it is reliable for medical decision making? Does this test incur any patient harm or discomforts or anything? And does it incur an additional cost, which is very important? Then the types of diagnostic designs for diagnostic test studies. So usually the design determines the reliability of the result or the data you are going to have. The most superior one that is being piloted is the diagnostic randomized study, which is a comparative study, and as well as an experimental. Then we have the diagnostic case control studies and the diagnostic cross-sectional studies. So each one of them have an advantage and have a weakness. The diagnostic randomized studies are usually prospective studies. They take a long time. They measure the effectiveness of new interventions and allows measurement of clinical outcomes easily. And they have the disadvantage of being high cost, long term, and usually has less statistical power. It means that you have to get a large number of participants for you to power up the study. In diagnostic cross-sectional study, usually I give an example, like all the participants enrolled they usually come for the screening, and they all are all exposed to the same studies, that is the FIT and the colonoscopy. The strength of this, it allows you to accurately calculate the diagnostic accuracy if it is actually done well, and it has little bias if it is performed well, and it can actually determine safety. The weakness is that if the new test is superior to the previous test, so is more accurate than the previous test, so it is difficult or impossible to know for sure if the reference or the new test provide the correct diagnosis. So you can't know which one gives the other one. Cannot compare the studies test to a test that is not actually performed. Maybe you cannot compare FIT to a study that you have not subjected your participants to it, and cannot give clinical outcomes most of the time. The diagnostic case control usually is you do a case control study. You have those that are having the disease and those not having the disease. So those that are having the disease, you use to calculate the sensitivity, while those that don't have the disease, you calculate the specificity, and you combine them as a cohort. So the weakness is usually it has a high risk of bias, and usually inflates sensitivity and specificity measures and lead to overestimation of test accuracies. I think I've come to the last aspect of the presentation. Thank you very much.
Yeah, thank you very much. Thank you very much, Dr. Sani. That was a wonderful presentation.
Sorry, is Dr. Mustafa, please?
Oh, sorry, Dr. Mustafa. Yeah, Dr. Mustafa. All right. Time for contributions, questions, clarifications. Any question, any clarification?
Sorry, Dr. Atta. I just tried to attempt the question. I am not a national candidate, but a West Africa candidate. So, but I saw it as an opportunity to just attempt and get maybe taught about something like that.
Yeah, thank you. Thank you. Thank you for.
Let me just comment on that quickly. Please, anybody can answer any question. We are all physicians, irrespective of your colleges, because you are going to defend your book. These are some of the information
yes.
that you need. And tomorrow, when you become a consultant, you'll be publishing and doing research. So these are the information you need. So it's not useless at all. So anybody can present any topic at all, because we are physicians, even if you're not going for national exam. Something like a guy that talked on clinical governance. This is what happens every day in the hospital. So do you understand? So everything is not about exam, real life situations too. I don't know if you get that. So please comment from the participant, please.
Dr. Eunice is saying, please, what type of study should be used? Study design should be used. Cross-sectional or randomized clinical trial?
Yeah, as it is recently proposed, the diagnostic randomized control trial is called is the best method that you can use, because you have the advantage of getting what we call the outcomes. And you also be able to calculate survival. You will be able to calculate your accuracy tests as well. So diagnostic randomized control trials are better than the cross-sectional. But the only disadvantage is that if you don't have time, so you can go for a cross-sectional study. But as far as this question is concerned, I will go with the diagnostic randomized control trial.
Any more question, clarification?
In the absence of any comments or questions, now to close this class is almost 8. I think the presenter did a wonderful job. This topic, anything of research might not be so easy, since it's not something we do and traditional in this part of the world. So most times, it's not so easy. But the guy did well, really. He tried. If Chief Remigus Chief Chitu didn't make any comment, you go Kunuga. Just know that.
Actually, I've been in and out, but I don't think I heard him here. I didn't hear him say anything about the ROC or AUC.
Did ROC come?
He
What?
did. He
He
did.
did.
sir.
Okay, then that's fine. That's fine.
He did.
I was really impressed. He
These
did.
people don't make any comment. Just know you don't wear in research. So I must thank all our teachers for coming to class, our facilitators, our participants, and Dr. Attack. Good morning.